Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. This is currently my 82nd episode. That means there is a lot of content that has been covered, yet in many ways I have only scratched the surface of what you need to know for the ABR core exam. One difference between learning in a topical manner, for example, focusing episodes on mediastinal masses, which I have done over the most recent 2 episodes, and actually taking the core exam, is that you don't have the luxury on the core exam to focus on any single area in detail, but you are rather expected throughout the day to switch between various organ systems for clinical questions, various imaging modalities for physics questions, regulatory questions for the radioisotope safety or RISE portion of the exam, as well as questions on non-interpretive skills. Part of the primary challenge of the ABR core exam is that you simply have to have a lot of information at the same time on the same consecutive days. That is challenging because we tend to remember what we have studied most recently and sometimes forget what we learned weeks to months ago. Therefore, to help you test your ability to recall and to switch between disparate topics in a rapid manner, I am going to scatter some review episodes covering a variety of questions that have been discussed on prior episodes, in between my more focused episodes that cover a single topic or only a few topics in more detail on each episode. I hope this might be helpful for you. Feel free to share your thoughts with me on Twitter or Instagram at RadRevPodcast or theradiologyreview@gmail.com. A downloadable study guide of this review episode can also be downloaded for free at theradiologyreview.com. Without further ado, let's get into the questions and answers for this episode. First question: what is the half-life, preferred collimator, and principal energies detected of gallium-67? I cannot stress how high-yield nuclear medicine can be for the ABR core exam, and you definitely need to know foundational concepts such as what I have asked in this question about each radioisotope. The answer to this question is as follows. First of all, remember that gallium-67 is the general nuclear medicine agent, and gallium-68 is the PET agent. Gallium-67 has a half-life of 78 hours with energies that approximate 100, 200, 300, and 400 keV, with the majority of energies in the 100 and 200 keV range. Therefore, a medium energy collimator would be best. These energies of 100, 200, 300, and 400 keV are an approximation of truth, and you can go ahead and look up the more specific energies. However, I think for most board questions, simply remembering those photo peaks of around 100, 200, 300, and 400 keV will steer you in the right direction. And if you remember that the majority of the emissions are in the 100 and 200 keV range, that should guide you to correctly deduce that a medium energy collimator would be optimal for gallium-67. Gallium is one of the few agents that will have lacrimal gland uptake. So if you see lacrimal gland uptake on a nuclear medicine scan from a gamma camera, think gallium first. With gallium, liver uptake often exceeds splenic uptake in a normal case. And key uses for gallium-67 include spinal osteomyelitis, for which gallium has better sensitivity than a tagged indium or technetium white blood cell scan. And gallium can also be used for cases of pulmonary infection, such as suspected PCP in a patient with HIV, where you would expect to see diffuse lung uptake if positive for PCP infection. The critical organ for gallium-67 is the colon. Next question. How do you safely receive a shipment of radioactive materials? The answer of this question can be broken down into several steps, and I think generally the following guidelines should steer you in the right direction on radiology board exams. To receive a shipment of radioactive materials, first, wear gloves and a radiation monitoring badge. Second, inspect the package for any visual signs of damage or leak. If the package appears damaged, notify your radiation safety officer. Third, check for external radiation first at 1 meter from the package with an ion chamber detector, and then at the surface with a wipe test. Remember that the radiation level you detect at 1 meter from the package must fall below that dose that is indicated on the transportation index in the small rectangular box towards the bottom of the diamond radioactive label. It is very important to know what the transportation index is and how this is used, and you can refer to my prior episode on this topic and the downloadable study guide to review this and other steps. If the radiation level that is detected at 1 meter is different than the transportation index, then you must notify your radiation safety officer and await further instructions. Also, for the external wipe test, a 300 centimeter squared surface of package should be wiped and assayed within a well counter. For the wipe test, refer to institutional policies, but generally something like 220 disintegrations per minute per centimeter squared is a common limit at which you must stop and notify your radiation safety officer. If your wipe test comes in under this allowable amount, you may be able to decontaminate the package and proceed, although you would still notify the radiation safety officer. If the amount of radiation is under something like 22 disintegrations per minute per centimeter squared, you should be good to go without decontamination or notifying your radiation safety officer unless otherwise specified by institutional or other policies. Assuming you have passed the external radiation survey, you are then okay to remove the packing slip. Once you remove the packing slip, ensure that the correct material went to the correct recipient. Fifth, open the outer and inner packaging and confirm that the contents match that on the packaging slip. Sixth, visually inspect the shielded container that was shipped to you for damage. If you see any damage, wipe the container and assay it in the well counter. If everything appears okay in terms of the shielded container, don't forget to remove the radioactive labels and discard. You cannot discard the container with the radioactive label in place. That is important to remember. Eighth, record the receipt of your package. The Nuclear Regulatory Commission requires records to be kept for something like 3 years, and agreement states may be something like 3 to even 5 years. Remember that agreement state regulations in general must be at least as strict as that established by the Nuclear Regulatory Commission and can be even more strict if desired, but they cannot be less strict than the Nuclear Regulatory Commission. Ninth and final step, return the empty, reusable shipping boxes to the vendor. Before you send it back, ensure that no contamination is present on the package and decontaminate if necessary. And again, make sure to remove the radiation label from all packaging. Next question. What is ishajju syndrome? Ishajju syndrome is notable for acro-osteolysis of the hands and feet. This is a familial condition that is autosomal dominant. In general, any autosomal dominant diseases have a propensity to become high yield for the ABR core exam, so pay attention when you notice this. Other features of ishajju syndrome include a short stature, craniofacial abnormalities, Wormian bones, polycystic kidneys, and neurologic symptoms. Next question. What are common upper lobe predominant lung diseases? Upper lobe predominant lung diseases include pneumoconioses, and you absolutely need to remember that pneumoconioses tend to be upper lobe predominant, and that includes entities such as silicosis, co-workers pneumoconiosis, progressive massive fibrosis, berylliosis, and inhalational talc pneumoconiosis. If you want more details on those, check out my upper-low predominant lung diseases episode that you could get on your favorite podcast directory, or if not, at theradiologyreview.com. Also, upper-low predominant lung disease can include tuberculosis, sarcoidosis, respiratory bronchiolitis interstitial lung disease, which can be abbreviated RBILD, Kaplan syndrome, that is Kaplan with a C, ankylosing spondylitis, allergic bronchopulmonary aspergillosis, or ABPA, centrilobular emphysema, cystic fibrosis, and Langerhans cell histiocytosis. Next question. For which indications is breast MRI recommended for high-risk screening? Breast MRI is recommended for high-risk screening for women with greater than 20% risk of developing breast cancer. This includes women with high-risk family history and/or known mutations, including untested first-degree female relatives with a BRCA, BRCA1 or 2 mutation, Li-Fraumeni syndrome, Cowden syndrome, Benayan-Riley-Ruvalcaba syndrome, chest radiation, which is often for lymphoma treatment that was received between ages 10 to 30 years old, and the ACR more recently has recommended breast MRI for high-risk screening for women with prior breast cancer who have dense breast tissue, or women with a history of premenopausal breast cancer. Knowing the indications for high-risk breast MRI screening is high yield for the ABR core exam, so make sure and review and understand these indications. Next question. What are common imaging features of papillary carcinoma of the breast? Papillary carcinoma comprises a rare subset of breast cancer that typically presents in a postmenopausal woman. On mammography, papillary carcinoma may demonstrate an appearance of a mass with associated suspicious calcifications. On ultrasound, look for a complex cyst with thick septations, or classically, a cystic mass with a vascular mural nodular component. On MRI, expect an enhancing complex cyst with irregular enhancing nodular components. Papillary carcinoma could also present as a solid mass without cystic components, but it is probably less likely to show up on a board exam with this appearance. I think it is more likely to be tested as an intracystic nodular vascular mass on radiology board exams. Differential considerations for papillary carcinoma of the breast include invasive ductal carcinoma with necrosis. Next question. What are common features by which neurofibromatosis type 1 is diagnosed? To diagnose neurofibromatosis type 1, you typically would need 2 or more of the following. First, at least 2 neurofibromas or 1 plexiform neurofibroma. Next, an optic nerve glioma. Next, greater than 6 cafe au lait spots in 1 year. Next, axillary and inguinal or intertriginous freckles. Next, osseous involvement. Next, sphenoid wing dysplasia. Next, pseudoarthrosis. Next, 2 or more iris hamartomas, which are also called Lisch nodules, Lisch. And finally, a first-degree relative with neurofibromatosis type 1. Next question. What is the difference between a stress fracture and an insufficiency fracture? A fracture that results from abnormal stress on normal bone is a stress fracture. A fracture that results from normal stress on an abnormal bone is an insufficiency fracture. Next, what is typically performed first for a VQ scan? The ventilation or the perfusion scan? For a VQ scan, ventilation is typically performed before perfusion. Next, what radiotracers are commonly used for the ventilation portion of the VQ scan, And what are the energies of these radio tracers? First, you need to know xenon-133 can be used for the ventilation portion of a VQ scan, and xenon-133 emits an energy of 81 keV. Remember that xenon-133 is lipophilic and requires a negative pressure room when you use this. Because xenon-133 is lipophilic, a classic board question is writer per quadrant abdominal uptake on a VQ scan, and if you are using xenon, that can be a sign of fatty liver disease or hepatic steatosis. The other radiotracer that is commonly used for the ventilation portion of a VQ scan is technetium DTPA or technetium technogas, which is more commonly used outside of the United States. And because those are technetium-based, the energy is 140 keV. Last and final question for this episode. What radiotracer is commonly used for the perfusion portion of a VQ scan? The answer here is technetium MAA, which stands for macroaggregated albumin, and as a reminder, this is a technetium agent, so the energy would also be 140 keV. That is enough for now. I hope that some of these review episodes I plan to release allow you the opportunity to check in and see where you're at with your learning and preparation. Remember that a free downloadable study guide covering these questions is available for your review for free at theradiologyreview.com. You can also find other materials at theradiologyreview.com that may be of interest to you, including articles in the Radiology Review Journal, which you can also access for free. Keep up the good work and study hard. Remember that you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.